Welcome everyone. Today we are going to discuss how to manage cyanotic spells in children. First, let's discuss a case scenario. An 18-month-old male child comes to the emergency department of the pediatrics with complaint of crying, irritability, fast breathing and increasing dusky appearance as told by the parents. You examine the child and you find a high respiratory rate, that is tachypnea. The child is extremely irritable. The child appears to have severe central cyanosis, which is giving rise to the dusky appearance as told by the parents. The child has clubbing of fingers. The oxygen saturation measured is coming out to be 61% on room air. There is no audible murmur, and the patient has bilaterally normal vesicular breath sounds. So from this appearance or these findings, you think that the child is sick. So in a sick child, you can't take detailed history. There is no time for detailed history. You have to take brief history and start managing the child. So that brief history is called sample history. What is sample history? S stands for signs and symptoms. What are the main signs and symptoms for which the child is coming to you? So the signs and symptoms mainly in this case were irritability and poor feeding. What does the A stand for? A stands for allergies or any known allergies. The parents tell that there is no known allergies in this child. M stands for medication. Is the child under any medication or has the child taken any previous medications? The parents are telling that the doctor who had seen the child at 6 months of age had advised them some unknown tablets and syrup which the parents are not able to describe clearly, but the compliance is questionable. That means they had taken the medications, given the medications to the child sometimes stopped according to their convenience. P stands for past medical history. That means if the child is having any previous medical history, significant previous medical history, they are telling that the doctor who had examined the child at 6 months had told that the child has some heart disease which will make the baby appear dusky or bluish. But the parents are not able to describe exactly that what disease exactly the child had, or they are not able to produce before you any reports or prescriptions of the previous doctor also. L stands for the last meal taken. Last meal taken by the child was 1 day before at night. Last meal taken, why it is important? For various reasons. First thing is, when the patient has taken a last normal meal, that means that was the time most probably when the child was apparently alright or apparently normal. Second thing is, if any procedures will be needed in near future, you may need to know the intake history so as to administer the anesthesia. So for that purpose also the last meal taken is important. And last is E. E stands for events leading to current hospitalization. So why did the parents bring the child to you now? So this early morning the patient did not take any feeds and was extremely irritable and had inconsolable cry. That's why the parents got worried and they brought the child to you. So you obviously don't have any time for investigations. So you ask if there is any previous investigations done in this child. The only thing that the parents have is this X-ray that was done some 1 year or 6 months ago. So from this X-ray you are able to know that there is pulmonary oligemia as evidenced by the absence of bronchovascular markings in the medial and lateral one third. The bronchovascular markings are mainly present in the medial one third only. Middle and lateral one third don't have any bronchovascular markings, so pulmonary oligemia. Second is the wide base of the heart, which is indicating in a right ventricular hypertrophy most probably. The upturned cardiac apex and the narrow pulmonary bay, which is indicating a less blood flow into the pulmonary circulation, and the obvious absent thymic shadow. In an infant or a toddler, the thymic shadow should be present, but in this case the absent thymic shadow is there, indicating or representing a narrow cardiac stem. So from these things, the diagnosis is not in doubt. The diagnosis is tetralogy of Fallot. We know, any pediatrician can know clearly. But the question comes how to manage this child. So coming to the topic proper, what is a cyanotic spell? The cyanotic spell is also known as a hypoxic spell or hypercyanotic spell or TET spell. So what does the mean by TET spell? The TET comes from the tetralogy Fallot, which is the classical condition in which the cyanotic spell is seen. So cyanotic spells can be seen in any conditions associated with Fallot's physiology. Fallot's physiology means uncorrected congenital cyanotic heart disease with decreased pulmonary blood flow are known as having Fallot's physiology. So what are the conditions? First condition is obviously tetralogy of Fallot, which comes under Fallot's physiology. Double outlet right ventricle with BSD with pulmonary stenosis also comes under Fallot's physiology. transposition of great arteries plus VSD plus PS also comes under phallus physiology. Many conditions can come under phallus physiology. So basically any uncorrected congenital cyanotic heart disease which is having decreased pulmonary blood flow can come under phallus physiology. They will have the same hemodynamics or similar hemodynamics. So the main mechanism of cyanotic spell is sudden increase in right to left shunt. We'll understand this now. So to understand this, first we need to understand the schematic diagram of normal heart. What is the schematic diagram of normal heart? In this picture, the blue chambers are the right side heart chambers and the red chambers are the left side heart chambers. So what are these chambers? This vessel here is the superior vena cava and inferior vena cava. This is the schematic representation of the superior and inferior vena cava. This is draining into the right atrium, which is draining into the right ventricle via the tricuspid valve, and the right ventricle is pumping into the pulmonary artery. Next, coming to this, the pulmonary veins or the four pulmonary veins are schematically represented here by a single vein which is draining into the left atrium. The left atrium is draining into the left ventricle via the mitral valve, and the left ventricle is draining into the or pumping into the systemic aorta. So this is the schematic diagram of normal heart. But schematic diagram of normal blood flow in a normal heart. So the blood will come from the superior vena cava and inferior vena cava into the right atrium, from where it will be pumped into the right ventricle via the tricuspid valve, from where it will be pumped into the pulmonary aorta. From there, the blood will go into the lungs, where it will get oxygenated, and the oxygenated blood will now come into the via the pulmonary veins into the left atrium. There it will be draining into the left ventricle via the mitral valve, and the LV will pump the blood into the systemic aorta. So this is the schematic diagram of normal blood flow. So now you have to understand what are the changes seen in a tetralogy of Fallot. Tetralogy means four things. So four things are wrong in the heart of a tetralogy of Fallot in comparison to a normal heart. What is the first abnormality? First abnormality is this. There must be a large VSD. So what is meant by a large VSD? Why not a small VSD? Large VSD means a communication between the right ventricle and left ventricle which is large enough to equalize the pressure between the two chambers. That is called a large VSD. If the communication is very large, the pressure between the two chambers will be equalized, almost equalized. So if the chambers pressures are almost equalized, the blood flow through this large VSD or shunt through this large VSD will depend upon the marginal disparity of pressure between the two ventricles. For example, if the RV pressure is more than the LV pressure, the shunt will be from RV to LV. If this side pressure is high, this side pressure is low, the blood will flow from the chamber of higher pressure to the lower pressure, that the shunt will be right to left shunt. On the other hand, if the LV pressure will be higher than the RV pressure, the shunt will be from LV to RV, that is left to right shunt. So this large VSD must be present in a tetralogy of Fallot. This is the first change seen in a case of tetralogy of Fallot. Second change, what is the second change? Second change is this. The RVOT obstruction, that means the right ventricular outflow tract obstruction. The right ventricular outflow tract obstruction, what does it mean? Right ventricular outflow tract consists of valve, the area above the valve, the area below the valve, that means the pulmonary valve. So the obstruction can lie anywhere. The obstruction to the right ventricular outflow tract, which can be valvar obstruction, subvalvar or infundibular obstruction, and supravalvar obstruction also. So obstruction may lie at any level, which is represented schematically here by a narrow pulmonary artery. So that means the obstruction at this level may be valvar, may be supravalvar, may be subvalvar. Basically there will be a right ventricular outflow tract obstruction. That is the second change needed in a case of tetralogy of Fallot. So what is the third change that can be seen in a tetralogy of Fallot? The right ventricular hypertrophy. There must be right ventricular hypertrophy. That means the walls of the right ventricle must be hypertrophied. So concentric hypertrophy of the right ventricle. So if there will be concentric hypertrophy of the right ventricle, previously we discussed in the first change, the right ventricular pressure or cavitary pressure will always be higher than the left ventricular cavitary pressure. So the predominant shunt in this case will be right to left shunt, not left to right shunt. So the third change is the concentric hypertrophy of the right ventricle. This is the third change in the tetralogy of Fallot. So what is the fourth change? Fourth change is the overriding of aorta or aortic overriding. Basically what is overriding mean? Overriding means a biventricular aorta. you look at the schematic diagram here. Biventricular aorta means both the left ventricle and the right ventricle pump into the same aorta. This is called biventricular aorta or the overriding of aorta. So what does the overriding of aorta mean? That is, both LV and RV behave as a single chamber and eject majorly into the systemic aorta. This is the four changes. So what are the four changes? A large ventricular septal defect, large enough to equalize the pressure between the two chambers, that is LV and RV, a right ventricular outflow tract obstruction, that may be supravalvar, valvar or subvalvar or infundibular. Third change is the concentric hypertrophy of the right ventricle. Fourth change is the overriding of aorta or the biventricular aorta. So what is the hemodynamics of Tetralogy of Fallot? So hemodynamics means first the blood or deoxygenated blood will come from the system supravena cava and infravena cava into the right atrium. From the right atrium, the blood will obviously go into the right ventricle via the tricuspid valve. Now look at the right ventricular outflow tract. Now the blood in the right ventricle has two possible ways to which it can go. One possible way is the pulmonary artery. One possible way is the systemic aorta because of the biventricular aorta or aortic override. So this way the blood can go, this way the blood can go. The blood that goes into the pulmonary circulation, the small amount of blood that goes into the pulmonary circulation will get oxygenated and return via the pulmonary veins into the left atrium. From there the oxygenated blood will go via the mitral valve into the left ventricle, and from there it will get pumped into the systemic aorta. But the important thing to note here is that the blood that was getting inside the right ventricle and without getting oxygenated, it was going into the systemic aorta. That means that amount of deoxygenated blood is going into the systemic circulation. That means in the systemic circulation there is mixture of deoxygenated and oxygenated blood. So that will lead to a fall or decrease in oxygen saturation, and in turn will clinically manifest as cyanosis. So this is the hemodynamics of a tetralogy of Fallot. Both ventricles behave as a single chamber and pump their blood into the pulmonary and systemic aorta. Pulmonary blood flow, if we represent it as QP, and systemic blood flow, if we represented QS, the pulmonary to systemic blood flow ratio, that means the ratio of blood flow into this pulmonary circulation and the systemic circulation, will depend upon the systemic vascular resistance and the pulmonary vascular resistance. We will understand this just 1 minute later. So the important thing to know here is that as there is no blood flow, or as there is least or less pressure gradient between the RV and LV through the ventricular septal defect, there is no shunt murmur. No murmur is there because of the ventricular septal defect shunt, because the pressure gradient between the LV and RV is very less. Rather, the increased amount of blood flow or the normal amount of blood flow through a narrowed valve, narrowed pulmonary valve or a narrowed right ventricular outflow tract will cause a murmur. That will lead to a flow murmur that will manifest as an ejection systolic murmur in the pulmonary area. So the only murmur present in a normal case of tetralogy of Fallot or case of tetralogy of Fallot normally is an ejection systolic murmur that is due to the amount of blood flowing through a narrow right ventricular outflow tract. That is an ejection systolic murmur. So this is the hemodynamics of a tetralogy of Fallot case. So the two dynamic parameters or the two parameters that can change from each heartbeat to heartbeat are the right to left shunt, that is this one, and the pulmonary blood flow, that is this one. So we need to understand those two things better. So what does the right to left shunt mean? The right to left shunt means the blood coming from the right ventricle and entering into the left ventricle, or coming from the right side of the heart into the left side of the heart. So what does the right to left shunt mean? The right to left shunt will be directly proportional to the severity of cyanosis. That means the more deoxygenated blood will come from the right ventricle into the systemic aorta, the more severe will be the cyanosis, obviously. And second thing is pulmonary blood flow. It will be inversely proportional to the severity of cyanosis. That means the more blood will get oxygenated by going into the pulmonary circulation, the less there will be cyanosis. That means there are two dynamic parameters of the right ventricular outflow. One is right to left shunt, another is pulmonary blood flow. The more the right to left shunt, the more will be the cyanosis. The more the pulmonary blood flow, the less will be the cyanosis. That means we have to know what are the parameters or what are the conditions in which or which will control the amount of right to left shunt, and what are the parameters which will control the amount of pulmonary blood flow. The conditions that will increase the right to left shunt will cause increased severity of cyanosis. The condition that will decrease the right to left shunt will cause decrease the severity of cyanosis. The conditions which will increase the severity or increase the degree of pulmonary blood flow will cause decrease in severity of cyanosis, and vice versa. The condition that will decrease the pulmonary blood flow will cause increase in severity of cyanosis. So coming to four basic parameters. If the pulmonary vascular resistance will be high, that means this pulmonary vascular resistance will be high. That means the blood inside the right ventricle has two ways to go. One is the pulmonary circulation, one is the systemic circulation. If the pulmonary vascular resistance will be high, the pulmonary blood flow will obviously be less, and in turn the right to left shunt will be obviously high. So increased pulmonary vascular resistance will lead to increase in right to left shunt and decrease in pulmonary blood flow. That means increase in cyanosis. Conversely, if the pulmonary vascular resistance will be less, that means the blood will easily go from the right ventricle to the pulmonary circulation and less blood will go into the right to left shunt. So if there will be decrease in pulmonary blood flow, there will be decrease in pulmonary vascular resistance, there will be decrease in right to left shunt and increase in pulmonary blood flow, that will lead to decrease in severity of cyanosis. Similarly, if there will be decreased systemic vascular resistance, this is very important to understand, as this is a biventricular aorta, or the right ventricle is pumping simultaneously into the pulmonary circulation and systemic circulation. If the systemic vascular resistance will be less, that means the right ventricle will feel very easy to pump into the pulmonary, the right ventricle will feel very easy to pump into the systemic circulation. That means the right to left shunt will increase and the pulmonary blood flow will decrease. This is represented here. The less the systemic vascular resistance, the more the right to left shunt, and the less the pulmonary blood flow, which will lead to increase in severity of cyanosis. Conversely, when there will be increase in systemic vascular resistance, the blood will go predominantly into the pulmonary blood flow. That means where this place, and the right to left shunt will decrease. That means this will be lead to decrease in severity of cyanosis. So we have understood that basically increase in pulmonary vascular resistance or decrease in systemic vascular resistance will lead to increase in right to left shunt and increased severity of cyanosis. And on the other hand, any condition that will cause decrease in pulmonary vascular resistance or increase in systemic vascular resistance will decrease the degree of right to left shunt and in turn will decrease the severity of cyanosis. This will need to understand. Now you need to understand that what are the conditions that cause an increase in pulmonary vascular resistance, because the conditions that will cause an increase in pulmonary vascular resistance will cause an increase in right to left shunt, which will lead to increase in cyanosis and the occurrence of a cyanotic spell. So the most common mechanism thought of until recently is infundibular spasm. Infundibular means the area lying just below the pulmonary valve. If the muscles present in the area just below the pulmonary valve undergo contraction or spasm, that means the right ventricular outflow tract will feel more resistance while going into the pulmonary circulation. So the blood will rather go into the systemic circulation. That means increasing right to left shunt, increasing cyanosis, occurrence of a cyanotic spell. But there is no evidence that the spasm actually occurs. This is the first thing. Second thing is the infundibular area is actually consisting of disorganized muscle fibers with intermingled fibrous tissue that is non-reactive to catecholamines. If a particular area is non-reactive to catecholamines, that means it is less likely or very less likely that the spasm will actually occur. Third thing is a patient having pulmonary atresia, that means absent pulmonary valve, in which the spasm occurrence will not matter because the valve is atretic. They also produce spells, or they also are seen to have spells. Fourth thing, if there is no infundibular stenosis, rather valvular stenosis, that means the obstruction is at the level of the valve, which has a fixed resistance, they also produce spells. So there is very less chance, from all this evidence this is evident that there is very less chance that the right ventricular outflow into the pulmonary valve or the change in the resistance in the pulmonary valve area or the subvalvular area or the supravalvular area has actually an important role in the occurrence of a cyanotic spell. That means the important role of cyanotic spell is actually in the level of systemic vascular resistance. The conditions that will cause decreased systemic vascular resistance will lead to increased right to left shunt and occurrence of a cyanotic spell, and the conditions that will lead to increased systemic vascular resistance will lead to decreased right to left shunt and the disappearance of a cyanotic spell. So now So now coming to the hemodynamics of a cyanotic spell. If this is the schematic representation of heart with tetralogy of Fallot, look at this area. If any condition will be there which will increase the systemic vascular resistance, there will be decreased right to left shunt and increased blood flow through the pulmonary circulation. This will lead to decrease in cyanosis. So increase in systemic vascular resistance will lead to decrease in right to left shunt and increase pulmonary blood flow. So that will lead to decrease in the severity of cyanosis. On the other hand, if there will be decreased systemic vascular resistance, the right to left shunt will be more and the pulmonary blood flow will be less. So that will lead to increase in severity of cyanosis or the occurrence of a cyanotic spell. So any condition that will cause decrease in systemic vascular resistance will cause increase in right to left shunt and decrease in pulmonary blood flow, in turn leading to occurrence of a cyanotic spell. So what are the some common conditions, other mechanisms that can cause cyanotic spell? Suppose there is hypovolemia. If there is hypovolemia, that means less blood inside the left ventricle. So inside the left ventricle at the end of diastole, there will be decreased pressure. If there will be decreased pressure inside the left ventricle, obviously the right ventricular pressure will be more increased or more in comparison to the left ventricle. That will lead to increase in right to left shunt and occurrence of a cyanosis, increasing severity of cyanosis. So hypovolemia leads to decreased end diastolic pressure inside the left ventricle, which will lead to increase in right to left shunt, which will lead to increase in cyanosis. Second thing is, suppose any condition that is causing increased blood return inside the right ventricle, any condition that is causing increased blood return via the supravena cava and inferior vena cava into the right ventricle, that will lead to increased pressure inside the right ventricle at the end of diastole. So there will be end diastolic pressure higher inside the right ventricle. So the right ventricle to left ventricle gradient will be more. So there will be increased right to left shunt and in turn increased cyanosis. So increased blood return inside the RV will cause increased end diastolic pressure inside the RV, which will lead to increased right to left shunt and increased cyanosis. Third thing, if there is tachycardia, if the heart rate increases as a whole. So if the heart rate increases, we know that whenever there is tachycardia, the systolic duration is not compromised that much. Mainly the diastolic duration is compromised. So if there will be decreased diastolic duration, so there will be decreased filling of the left ventricle. So similarly, there will be decreased pressure inside the left ventricle at the end of diastole. So there will be increased right to left shunt. Increased right to left shunt means increased cyanosis. So hypovolemia, increased blood return inside the right ventricle and tachycardias are some of the other mechanisms that will lead to increase in right to left shunt and in turn increase in cyanosis and in turn increase occurrence of a cyanotic spell. So what are the clinical features of a cyanotic spell? The peak age of presentation of a cyanotic spell is 2 to 4 months and it is mainly precipitated by occurrences such like feeding, crying, defecation, increased physical activity shortly after the infant wakes up. There is obviously hyperapnea, there is rapid and deep respirations, because the more there will be cyanosis, the more there will be less oxygen delivery inside to the tissues, there will be more hypoxia, metabolic acidosis. The metabolic acidosis will try to be compensated by a respiratory alkalosis, that means increasing respiratory rate so that the CO2 will be washed out. That will lead to rapid and deep respiration, that is Kussmaul breathing or acidotic breathing. There will be irritability and incessant cry, like we discussed in our case scenario. There will be worsening of cyanosis, obviously, because there will be more right to left shunt, so and decreased pulmonary blood flow, so there will be worsening of cyanosis. And characteristically, we learnt that the murmur in Tetralogy of Fallot is actually due to the blood flow through the narrowed right ventricular outflow tract. So during a cyanotic spell, there will be even less blood flowing through this narrowed right ventricular outflow tract. So if there will be even less blood flow through the right ventricular outflow tract, there will be obviously decrease and even disappearance of the heart murmur or ejection systolic murmur. What are the complications? Mainly CNS complications are seen in case of cyanotic spell: seizures, limpness, stroke, brain abscess, and some cases it can be fatal also. So it is very important to diagnose and treat this condition. So what is the vicious cycle of cyanotic spell? This is the most common or most important slide to understand in case of cyanotic spell management. So basically we learnt that anything that is causing increase in right to left shunt is causing the cyanotic spell. So what are those conditions? First thing, if there will be decreased systemic vascular resistance, that was the point of our whole discussion. If there is decrease in systemic vascular resistance, it will cause increase in right to left shunt and increase in cyanosis. What other condition can cause increase in right to left shunt? Second thing is, if the baby will be crying, if the baby will be crying, the respiratory rate will be very high. If the respiratory rate will be very high, there will be inspiration expiration like that. So more inspiration expiration means more blood return inside the right ventricle. We discussed the mechanism. There will be more blood returning to the right ventricle via the superior and inferior vena cava. So there will be more pressure inside the right ventricle at the end of diastole. So there will be more right to left shunt. Third thing is, if the patient is having hypovolemia, we discussed before, if there will be more hypovolemia, there will be less blood inside the left ventricle, there will be less pressure inside the left ventricle, so right to left shunt will increase. Next is any condition that is causing tachycardia because of compromised diastolic duration that we discussed before, so excess of increase in heart rate. Fifth thing is, if there is any RVOT spasm or infundibular spasm, but that is a questionable thing. So any condition that is causing increase in right to left shunt will cause more deoxygenated blood to go inside the systemic circulation. So there will be at the tissue level decrease in partial pressure of oxygen, decrease in pH because there will be metabolic acidosis, and increase in PaCO2 because there will be increased generation of carbon dioxide. All these things, decrease in PaO2, decrease in pH, increase in PaCO2, will cause stimulation of the respiratory center. So that will lead to hyperapnea or increase rate and depth of breathing. The more there will be hyperapnea or the more the rate and depth of breathing will increase, there will be increased systemic venous return because there will be inspiration, expiration. So there will be negative pressure inside the intrathoracic chamber or intrathoracic area. There will be negative pressure. So that negative pressure will pull the blood from the superior vena cava and inferior vena cava. So there will be more systemic venous return. The more systemic venous return will occur, that will go into the right ventricle. The right ventricular end diastolic pressure will increase. The right to left shunt will further increase. So this is actually the vicious cycle that occurs once the cyanotic spell starts. So what we need to do to treat the cyanotic spell is, we have to block every single level of this vicious cycle. So let's see now what can we do to block all these things at each level. Suppose we want to decrease there is decreased systemic vascular resistance precipitating the right to left shunt. So what can we do so that the systemic vascular resistance will not decrease, or what can we do to increase the systemic vascular resistance? We can give the patient phenylephrine. Second thing is, crying was precipitating the right to left shunt or increasing the right to left shunt. So what can we do so that the baby will not cry? We'll give morphine to sedate the child. The more there will be sedation, the less crying, the less right to left shunt. Third thing, hypovolemia was precipitating the right to left shunt. So what can we do? We can give a hyperhydration. That means we can give a fluid bolus to correct the hypovolemia. Next thing, excess increase in heart rate was causing the right to left shunt to be increased. So to decrease the tachycardia, we can give a smaller, a beta blocker. Fifth thing, RVOT spasm, although a questionable entity or a questionable mechanism, still it was implicated in the past as a cause of right to left shunt, increasing right to left shunt, or a cyanotic spell. So to decrease the RVOT spasm, what can we do? We can give propranolol. Next thing, decrease in PaO2, decrease in pH, increase in PaCO2. Basically a condition or a state of metabolic acidosis. What can we do to correct that? We can give oxygen inhalation to increase the PaO2. What other thing we can do? We can give positive pressure ventilation, because giving the positive pressure ventilation will cause improvement in oxygen saturation and increase in pH. Next, what we can do? We can give sodium bicarbonate to correct the metabolic acidosis. If we give sodium bicarbonate, the metabolic acidosis will be corrected and this step can be blocked. Next is hyperapnea was also implicated. So to decrease the respiratory rate, what can we do? We can give ketamine. Ketamine, if we give, that will cause decrease in respiratory rate and also will help to sedate the child so that the hyperapnea will decrease. Last thing is, there was increased systemic venous return associated with right to left shunt. So what can we do to decrease the systemic venous return? We can give the patient, or you can put the patient in a knee chest position. So all these things we can do in the treatment of cyanotic spell so as to break this vicious cycle, because that is the only way we can treat the cyanotic spell. So all these things can do. So all these things we can do to manage the cyanotic spell. First thing is propranolol. It decreases the tachycardia, it decreases the RVOT spasm, and it also increases the systemic vascular resistance. Esmolol, it decreases the tachycardia because it's a beta blocker. Knee chest position, it traps the systemic blood in the legs. So as it traps the systemic blood in the legs, there is less blood flow going inside the right ventricle. There will be less pressure inside the right ventricle. There will be less right to left shunt, and it also increases the systemic vascular resistance. Ketamine, it increases the systemic vascular resistance and also sedates the patient. Phenylephrine, it increases the systemic vascular resistance. Morphine, it suppresses the respiratory center and decreases the tachycardia and sedates the patient. Oxygen inhalation improves the arterial oxygen saturation. Hyperhydration corrects the shock, acidosis. It decreases the hyperviscosity and increases the or improves the pulmonary blood flow. Positive pressure ventilation, it improves the oxygenation and decreases the systemic vascular resistance. And sodium bicarbonate, it corrects the acidosis, abolishes the respiratory center stimulating effect of acidosis. So these are the various doses of all these things. Propranolol is 0.01 to 0.25 milligram per kilo slow IV. Esmolol is 0.5 milligram per kilo over 1 minute followed by 50 microgram per kilo per minute 4 times. Ketamine is 1 to 3 milligram per kilo IV over 1 minute followed by an infusion of 1 to 4 milligram per kilo per hour with glycopyrrolate, so that there will not be increased secretions. Phenylephrine is given at 0.02 milligram per kilo IV. Morphine 0.2 milligram per kilo subcutaneous or 0.05 to 0.1 milligram per kilo IV over 10 minutes. Hyperhydration, we give the NS or RL bolus at 20 ml per kilo. Oxygen inhalation, we have to give at highest possible concentration in a non-threatening manner. Sodium bicarbonate is given at 1 to 2 milliequivalent per kilo diluted 1:1 with distilled water so as to avoid the sodium overload. May be repeated in 10 to 15 minutes. So if a patient of cyanotic spell comes, what are the steps? If a cyanotic spell is diagnosed, next we need to give oxygen at the highest possible concentration in a non-threatening manner. Then we have to give keep the patient in a knee chest position. Then we have to hyperhydrate the child by giving a NS or RL bolus at 20 ml per kilo. Then we have to give or we have to correct the acidosis by giving injection sodium bicarbonate 1 to 2 milliequivalent per kilo diluted 1:1 with distilled water over 5 to 10 minutes. May be repeated after 10 minutes. If all these steps don't work, then we need to move further. We need to sedate the child, abolish the tachypnea by giving injection morphine at 0.2 milligram per kilo subcutaneous or 0.05 to 0.1 milligram per kilo IV over 10 minutes. If this also doesn't work, we have to relax the infundibular spasm by giving injection esmolol. If this also doesn't work, we have to give, or if esmolol is not available, we have to give injection propranolol at 0.01 to 0.05 milligram per kilo. If this also doesn't work, we have to increase the oxygen delivery to tissues by PRBC transfusion so as to maintain the hematocrit over 45%. If this also doesn't work, we have to increase the systemic vascular resistance with pressures like injection phenylephrine or injection noradrenaline. If this also doesn't work, we have to increase the systemic vascular pressure further by giving injection ketamine with glycopyrrolate. If this also doesn't work, we have to correct the hypoglycemia, provide assisted ventilation and alert the cardiac surgeons, because the occurrence of a cyanotic spell in a patient of Tetralogy of Fallot is an indication to undergo corrective or palliative surgery. So what are the key learning points? Worsening of cyanosis, disappearance of murmur, hyperapnea, irritability in a patient with pathophysiology indicates cyanotic spell. The main mechanism is increase in right to left shunt caused by a fall in systemic vascular resistance. The immediate management is oxygen, knee chest position and breaking the vicious cycle. It can be fatal, cause severe CNS complications within seconds to minutes. So thank you everyone for your patient listening. If you like this video, you can hit like, subscribe and share with your friends and suggest more topics for future videos. Thank you.